Good evening, everybody. We'll give it a few minutes and let people log on. It's not quite 9 o'clock yet either. All right, let's go ahead and get started. I was not able to get these slides to upload. I have tried to contact somebody from Naxlex to try and upload them for me, but I will share mine with you all. And I've already sent them to them to try to get them to upload. We've had some bad weather here and electricity has been out. So I apologize for that, but I will see what I can do to get them uploaded to the site. Can y'all see that?
Yes.
So if you're okay, good. Because if you're commenting in the chat, I have to toggle back and forth between the site and the slides. So I'm Dr. Lapage. Good evening. Tonight we're going to talk about hematological and oncological pharmacology. Um, NCLEX doesn't get real specific as far as oncologic medications and pharmacology because it's such a specialized area. But we will talk about the chemotherapy and some of the agents used because some of those agents are used for other um, illnesses as well. And we'll talk about those in particular. So, upon completion of this presentation, the participant will be able to apply the pharmacokinetic principles of anticoagulants and antiplatelets to the care of patients with hematologic disorders, apply the mechanisms of action, side effects, nursing implications, and the evaluation process of those antiplatelets, anticoagulants, and heparin therapy to the care of the patients that are receiving them. Incorporate the nursing process in the care for these patients. Evaluate the effectiveness of these medications in relation to the disease processes and differentiate evaluations of the various lab results for monitoring the various medications, and then apply the nursing process to the administration of our basic chemotherapy agents. So, coagulation disorders. It's basically the body forms too many or not enough clot. Hemophilia is going to be those too many, and those bleeding disorders, which is genetic and it does affect more males than females. And it is considered a coagulation disorder because they bleed too much. So remember the composition of blood. Blood itself is a specialized body fluid. There's four main components: the plasma, the red blood cells, the white blood cells, the platelets. And there's those four different components play key roles when we're talking about some of our disease processes and actually coagulation. And then whole blood is going to run through the veins, the arteries, and the capillaries. And then it's a mixture of plasma and blood cells, which more with more plasma than those actual blood cells. Your average male has about 12 pints of blood, where your average female has only about 9 pints. So, remembering the genetic differences when we're talking about a lot of disease processes is going to be key. And then think about if males have more blood, they have more tendencies to bleed. So, the functions of the blood, remember, they're going to transport those oxygen and nutrients to the lungs and the tissues. And they do that with the hemoglobin because red blood cells contain hemoglobin. They form blood clots to prevent bleeding. They carry cells and antibodies to prevent or fight infection. They carry waste to the kidneys and the liver to filter and clean that. And then they regulate body temperature. So that's how we tie in if somebody has anemia. What is one of the first signs and symptoms? They're typically cold, or if they have low blood counts, or they have bleeding disorders, they tend to go into shock because that body is not able to regulate their temperature. So, our trauma patients, that are becoming hypovolemic, we want to cover them up. We want to warm them. We want to keep them at body temperature because that body is not able to regulate itself, especially if it's in a state where it's not able to coagulate or clot that blood. So the plasma is the liquid part of the blood. It's a mixture of water, sugar, fats, protein, salts. And the main job of the plasma is to transport blood cells throughout the body, along with those nutrients and the sugars and the fats and the proteins and the salts. Also carries waste products, antibodies, and then those clotting proteins that help with clotting. There also carries your hormones, which are considered your chemical messengers, and the proteins that help maintain the body's fluid balance. So that works with your electrolyte imbalance and your fluid and electrolytes. Because if the blood is, remember, electrolytes also carry your positive and negative ions, your potassium, your calcium, and your magnesium. So if we don't have enough circulating blood through the heart, it can lead to arrhythmias as well. Your red blood cells or your erythrocytes are going to count for 40 to 45% of that blood's volume. It is the most abundant cells in the blood. There are more of those than any other. The shape of them are those biconcave with that little ridge in the middle, the disc shape, and then that flattened center. They aid in the production and controlling that erythropoietin, which we also refer to as EPO. It's a hormone that's produced primarily, remember, by the kidneys. And the red blood cells start as immature cells in the bloodstream. They are unique and unlike any other cells, they have no nucleus and they can easily change shape, helping them through the arteries and the veins, kind of like this picture here. So it makes them more flexible. They're also, their lifespan is they begin as immature and they are forming in the bone marrow, remember, and then they don't have a nucleus as well. So remember, most cells have nucleus, your blood cells do not. They do survive about an average of 120 days. And then, like we talked about, they carry the they contain hemoglobin, which carries the oxygen. Your white blood cells, we all know, are going to fight your infection. There is a less amount of those in the red blood cells. So patients who are immunocompromised and have illnesses that affect those white blood cells, and your chemotherapy patients that develop low platelet counts and low white blood cell counts are going to be more at risk. It does consist of 1% of the volume of the blood. And then the neutrophils are the most common types of your white blood cells. They survive less than a day. And then they're made up of two different types, your lymphocytes or T cells, and then B cells as well. Then your plasma is your thrombocytes. It's not considered a cell at all. They are small cell fragments that circulate within the blood, and they help the blood with the blood clotting process, which we also know as coagulation. They stick to the lining of those injured vessels, and that's where we wind up getting the clots that form. They're going to stick because of our platelets as well. So hence that's why we talk about antiplatelets, because remember, normal platelets, if there is a clot forming, they're going to stick to them because of their stickiness. Remember, they stick to the lining. So if somebody's having an MI and they already have a clot, we give them antiplatelet medications to keep those platelets and the plasma running so that it doesn't cause a larger clot and occlude more. They form fibrogen. To help prevent further bleeding. And then that increased clotting requires those anticoagulants and antiplatelets. So if a patient is clotting too much, which is those patients that are prone to your pulmonary embolisms or your DVTs, we're going to keep them on those antiplatelets or anticoagulants. Think about the disease processes like your atrial fibrillation that are prone to developing clots, which is why they're on those anticoagulants. And then decreased clotting is going to require your clotting factors. Some of your coagulation disorders are going to be your hemophilia, the von Willebrand's disease. Patients who have liver disease can have coagulation disorders. Remember all the functions of the liver, and when you go back and look at those, again, it's vitamin K production. And these patients who have vitamin K deficiency are going to have coagulation disorders. Patients with anemia, patients who've had a stroke, they have too much coagulation, which develops those clots. And then patients with cardiovascular disease, because they get that plaque that develops, it's going to cause those platelets and the plasma to stick. Any questions so far?
No.
Okay. So, what are some indications for our antiplatelet medications? Well, your acute coronary syndrome, which again, that's why we give antiplatelets or aspirins if patients are developing chest pain, because we don't want those platelets to stick to that clot and form a bigger clot. Your patients who are post percutaneous coronary intervention with stenting, because now they have a foreign body in their body, right? And remember, anytime a foreign body enters our body, we're going to send all of those clotting factors to it, and they can form clots there. Anybody who's got a mechanical heart valve, because that heart valve can stop and it can also malfunction, so it can cause those clots to form. Anybody with atrial fibrillation, stable angina, acute ischemic stroke, we give it to. And then patients who've had post coronary artery bypass grafting surgery or your cabbage. Patients who have essential thrombocytosis, because that is a disorder where the body produces too many platelets that can cause blood clots or bleeding. So we need to keep them on those antiplatelets to prevent the blood from clotting. Prevent coronary artery disease. Again, remember, most of our patients are on baby aspirin, which a lot of times students get confused and want to say that aspirin is an anticoagulant, and it's not, it's an antiplatelet. Prevention of colon cancer, Kawasaki's disease for our children. Remember, that's your rare disease that causes inflammation. And anytime there's inflammation, we can also get blood clotting. Acute rheumatic disease, post patent ductus arteriosus. Typically, they do a closure within the first 6 months of life for our kids. Patients with acute pericarditis, and of course, we all know our atrial fibrillation patients. So, the actions of those antiplatelets, again, is that platelet aggregation inhibition. There's several different actions. There's also glycoprotein inhibitors, your protease activated receptor 1 antagonist. And each of them are going to be a little bit different in their classification. And they're going to be your aspirin, your antiplatelets, your clopidogrel, your Plavix is going to be your medications that I call less we use them for the lesser diseases, where if your patients are really on your ReaPro or your Integralin, they're having some definite platelet they need those strong antiplatelets, and those are all going to be IV medications. The protease activated receptor 1 antagonist, there's only one out there, and it's called Zontivity. I personally has never given it. I have given the Integralin, the Aggrastat, and the Reapro, especially for our our coronary um, artery disease patients and those who've had an MI when our facility did not have a cardiac cath lab, and we needed to get them downtown to Atlanta. We didn't have an interventional cardiac cath lab. We didn't even have any cardiac cath lab when I first started working here. Um, and then we got the cath lab, and then we got the interventional. But prior to that, we needed to stabilize these patients that were having active MIs, because the closest facility by helicopter was 17 minutes and by ground was at least 30, depending on the time of traffic and how fast the ambulance could go. So we would use a lot of those Reapros, the Integralin, and the Aggrastat to kind of hopefully stabilize these patients until they could get to the interventional cath labs. There are contraindications with these antiplatelets because, again, remember, they affect clotting. So, anybody who has bleeding disorders, an active GI bleed, your esophageal varices, anybody who's got severely decompensated liver disease, because again, once that liver disease and that liver starts to fail, it can't produce those clotting factors and it can't produce that vitamin K. Anybody with an intracranial bleed. And then patients who have, it's a triad, it's called Samter's triad, with your nasal polyps, asthma, and then aspirin allergy. And obviously, anybody who has an aspirin allergy can't take an antiplatelet medication. Any questions?
No.
We're all good? All right. So, what are some side effects? The biggest one that patients complain about is that GI upset. A lot of times, patients will say they're allergic to aspirin because of that GI upset. So, our job as a nurse is to actually investigate and assess more what exactly is your allergy. If it's an upset stomach, then there are things and interventions we can do where we have to look at, do the benefits outweigh the risks of taking this medication. Anybody who has aspirin allergy or aspirin can induce asthma attacks. So we really want to monitor these patients. Anybody who's got hematuria, gastritis, and epistaxis are some of your side effects, as well as that thrombocytopenia. And the one thing we all know about is tinnitus, the ringing in the ear. The tinnitus and the ringing in the ear is one of the first signs that these patients are developing aspirin toxicity. Um, they get the ringing in the ears, a severe headache, really bad, severe nausea and vomiting. And then it can progress to hyperventilation, confusion, and hallucinations, depending on how high their salicylate level is. So the normal salicylate level is 15 to 30 milligrams per deciliter. So it was probably about 10 years ago, we had um, TikTok. It was right when TikTok came out, may have been less than 10 or 15 years ago, but we had a rush of a bunch of teens coming in. They were doing the cinnamon challenge and the aspirin challenge and acetaminophen challenge, where they were taking as many as they can. And these patients were winding up becoming toxic they were choking on the cinnamon when they were trying to, I don't know if it was TikTok or whatever it was on, but they were doing all these challenges. Young, kids that don't really have mature brains and they're trying to prove something. But they were doing these challenges, and we saw a rush of young kids coming into the ER toxic on acetaminophen and salicylate, which is your aspirin. So, unfortunately, with both, with acetaminophen, we can give mucomist and acetylcysteine. But if it's severe, they need hemodialysis. With the aspirin toxicity, hemodialysis is the only thing that's really going to help them. So, a lot of education with these patients, especially young kids. Here in the state of Georgia, um, they cannot buy decongestants, aspirin, acetaminophen, or cough syrup over the counter. They have to be 18 years old and they have to show identification. A couple weeks ago, I sent my daughter to the store. She's 23, but she didn't bring her driver's license in and they wouldn't sell her the cough syrup for me. So they're pretty strict. I guess it depends on where you're going, but so some of our nursing interventions with our antiplatelets, definitely give it with food, provide safety, monitor for bruising. We want to educate these patients to use soft bristle toothbrushes and to use electric razors because, again, that decreased clotting factors or those antiplatelet effect can lead to bleeding. Make them adhere to, or not make them, but request and try and help them to adhere to their regular physical visits so that they can get that blood work and monitor it. Obtain a good baseline assessment on these patients as well. Does anybody have any questions on antiplatelets?
No.
So, what are anticoagulants? They're a classification or a family of medications that work to stop clotting. Some can stop clots from forming. Some can work to prevent, we use them to prevent life threatening illnesses such as your stroke, your MI, and your pulmonary embolisms. They are available sub Q, PO, IV, and then IV infusion. Not every drug is available by those routes. So when we're talking about our sub Q and our IV push and our IV, that's going to be your heparin medications. Your sub Q is going to be your enoxaparin, and then your PO is going to be your warfarin. They are very frequently prescribed, especially to our older population. And a lot of our older patients who have atrial fibrillation are taking those anticoagulant medications. There are new ones that are out on the market. Your Xarelto and oh, it just went out of my head. But there are no reversal agents for some of those. And if there is a new reversal agent for the Xarelto. However, it's about $26,000 a vial. And oftentimes, these patients they can get up to 12 vials. The drug reps will give you a really good dinner to try and get you to talk your hospital into getting it on their formulary, but it's very hard to get that medication because it is so expensive. In
They
my
have one
career,
called Apixaban also.
what is it?
Eliquis.
Yeah, Ella, that's the one I was trying to think of. Yes, thank you, Eliquis. Um, in my life, well, in my career in the ER, since these medications have come out, I've seen two patients who have actually one had a poor outcome and one had an okay outcome. It was very touch and go for a while, but there was a lady who, ironically, the Xaralto rep was feeding us lunch when they first came out with it. And there was a 72-year-old lady who came in unresponsive by EMS, was found in her living room. She didn't pick up her friend to go to the church luncheon. So the friend called the daughter. The daughter went over there and she was passed out on the floor. Turned out this lady had a hemorrhagic stroke, a head bleed, and the only medication she was on was Eliquis, no medical history. She drives, she walks, she was very healthy, except for the fact that she had atrial fibrillation, and they had just put her on the Xarelto. She went, unfortunately for her, the head bleed was so severe that she did not make it. I also took care of a patient. I had a new graduate precepting with me, and this gentleman came in. We actually thought he was having a dissecting aneurysm, and it wound up being a retroperitoneal bleed. And the medication he was on, it was a spontaneous bleed, no injury, no trauma. He wound up going to interventional radiology, but it was touch and go for quite a while. We were hanging a lot of bags of fresh frozen plasma on him in hopes to get it built up. But again, that's just buying us time. He wound up with 7 coils or clips to stop that retroperitoneal bleed. And we were actually kind of measuring it and watching him, but we could actually see his retroperitoneal area get bigger and bigger. And as it got bigger with more bleeding, his blood pressure was dropping. So he became very hemodynamically unstable. um, there was a push between interventional radiology and the emergency doctor because they did not want to take this patient because his INR was so elevated. Well, his INR was so elevated because he was bleeding, and what he needed was to go to the interventional radiology and have the clips and the coils put in to stop the bleeding. So it took us a good little while to get the patient and for them to agree to take him because he was so unstable. But the reason he was so unstable was because he had the bleed. So there's some good and some bad with um, these different medications, but being aware that your patient is on them is key as well. Um, there are several forms, your heparin and your heparin derivatives. There's unfractionated heparin, which is your basic heparin and your heparin infusions. We can give that sub-Q. We can give it IV push and IV infusion. And then your low molecular weight heparin, which is your enoxaparin. All of those, or both of those, the antidote or the reversal agent is your protamine sulfate. Fondaparinux is also another form of heparin. And then your direct thrombin inhibitors and your um, direct oral inhibitors, which is your warfarin. Any questions so far? We good?
Yes, ma'am.
So your heparin derivatives or your heparin and its derivatives is a medication that's going to inhibit those clotting factors by activating the body's own anti-clotting processes. One of the anti-clotting processes that's used is a type of blood protein called that antithrombin, which we all make. Everybody makes it in their body. And then it works by the heparin works by activating that antithrombin to stop those other clotting processes. So I'm sure y'all have given heparin in your um, schooling or career because it's very we use it even prophylactically. There's a lot of uses for it. We use it for pulmonary embolisms. It's just a frequently used medication. The unfractionated heparin is stronger and more faster acting. They are longer molecules, and these require those constant monitoring. They go in various doses according to what the patient's lab levels are. What lab do we use to monitor heparin levels?
APTT.
PTT.
Yep, your PTT. So we vary that. They have come out within probably about the past 5 years, um, um, a serum lab that we measure, which is more specific, called the heparin assay. So in a lot of our facilities, we now monitor the heparin and adjust the heparin, titrate the heparin according to the heparin assay results. Heparin is a weight-based medication, so one of our nursing interventions requires us to weigh these patients every day because patients lose weight, they gain weight. If we don't give them, if they lose weight, then we're giving them too much heparin if we're going by the old dose. And if they gain weight or fluid, they're not getting enough. And we know that fluid and cardiac problems can cause clotting problems as well. So it's not a good situation. We definitely need to be weighing these patients. Your low molecular weight heparins are going to be your Lovenox. They are shorter molecules and they only attach to the antithrombin. They are a little more predictable and they don't require as close monitoring or as frequent monitoring. The Fondaparinux is a synthetic form of heparin. It is very similar to heparin, where it activates that antithrombin, but it lasts longer than your low molecular weight heparin. Your direct thrombin inhibitors are going to attach to thrombin and they keep it from assisting the clotting. They're used as alternatives to heparin, which is going to be your Angiomax, Ipravasc, and then Acovia. I've never administered Acovia or Ipramax, but I have administered Angiomax before. And then your warfarin and Coumadin, which is considered a vitamin K antagonist. That's why vitamin K works to reverse the effects of that warfarin, and it's going to block the use of that vitamin K. So that's why the vitamin K works to stop it or to reverse it. Sorry. It does require careful dosing. It requires more stringent and regular lab monitoring. And what do we monitor warfarin with? What lab?
INR.
INR.
INR, yep. And warfarin can lead to severe bleeding. Several years ago, we had it was Snowmageddon in Atlanta. People were actually, it was almost 11 years ago now, but it was crazy. It was an ice storm. People were on the highway. They were stuck on the highway. A couple of the nurses I worked with were stuck on the highway. But on the third day, all the ice started melting, and we had a big rush coming into the ER of these older patients that were coming in with head bleeds, and they were all on Coumadin. Well, we realized, you're stuck in the house for 3-4 days. Now they're starting to walk to the mailbox. They're starting to walk outside, but the ice was all melting. My whole city and my whole route to the hospital where I work at, it's 9 miles from my house. I was like driving on ice the entire way. But I slept at the hospital on my shift, but people were coming in because the ice was melting. They were stuck in the house. They were walking out there. The ice was melting and they were slipping and falling. So most of them were on warfarin and Coumadin. And you hit your head, that's what you have to suspect, that they're on these anticoagulants. It can lead to that severe bleeding. It can also lead to severe GI bleeding as well. So, again, careful monitoring of these medications is key. Your direct oral anticoagulants, they don't require regular lab testing. Apixaban, the dabigatran, and the betrixaban, they are similar to their IV thrombin inhibitors, and they also are going to inhibit and stop the clotting factors. Any questions?
No.
So, what are our anticoagulants? Remember, they're the group of medications that keep the blood from clotting. So they prevent blood clots. We use it for atrial fib, MI, pulmonary embolism, or to prevent pulmonary embolisms. We use it prophylactically for hip and knee replacement surgery. And then patients who have frequent or DVTs, they may also get, or well, if they have an active DVT or a diagnosed DVT, they're going to be put on your heparin or your Lovenox. They may be weaned off of, or they will be weaned off of it, and they may be on warfarin or one of your other anticoagulants for several months, if not forever, depending on the PE and the disease process. The dosages are going to vary depending on the type and what we're using it for. And again, it depends on whether it's the heparin or it's the warfarin. The heparin is weight based. The warfarin is typically going to be 2.5, 5, 7.5, or 10 milligrams. These patients may take it every day. They may take it every other day. They may alternate one day 5 milligrams, one day 7.5, or one day 2.5, and one day 5. What are your side effects? Easy bruising, bleeding gums, a lot of GI effects. These patients complain of shortness of breath sometimes. And again, your elevated liver enzymes. And then if we're giving it sub-Q, they can have pain or irritation at that injection site, which is why one of our nursing interventions is to alternate and change sites. We're going to monitor those specific labs, administer the reversal agent as needed. So for warfarin, what is our reversal agent?
Vitamin K.
Vitamin K. What is the reversal agent for Lovenox?
Protamine sulfate.
Protamine
Vitamin
sulfate.
sulfate.
Yep. And the reversal agent for heparin?
Protamine sulfates.
Protamine sulfate. Good. So we're definitely going to educate them to prevent injury, to use electric razors, and to use soft toothbrushes, because one of the first places that we see bleeding is in the gums, especially if they're brushing their teeth too forcefully. So there's your reversal agents. I gave you some examples: your heparin, your Lovenox, and then your warfarin or Coumadin, which is all the medications that we've talked about. Any questions on the anticoagulants before we move on to the chemotherapy agents?
No.
Do y'all feel comfortable with anticoagulants? I'm sure you probably give them a million times, right? So, chemotherapy agents, they are drugs. They are grouped by how they work or what their chemical structure is, and also their relationship to other chemotherapy agents. Some drugs work more than one way. Some can treat autoimmune disorders and blood disorders. And then they can belong to one or more group, or they can belong to one group and then two groups. Lots of times we use, or they use, a combination of the chemotherapy agents. So, what do you think it's important for you to know relating to chemotherapy agents? Do you think you need to know the specific ones?
Yes.
Well, you don't really need to know specific chemotherapy agents. You do need to know more of a basic, broad. Um, how are you going to care for a patient who's on a chemotherapy agent? So, what are the priority nursing interventions for somebody who's on chemotherapy? What's your goal?
Neutrophy precaution.
Well, not everybody's on neutropenic precautions if they have chemotherapy. My friend
Infection.
my friend she had breast cancer, had surgery the day after New Year's, and she is on a 5-year plan of an oral chemotherapy. So she's not on neutropenic precautions. But overall, what do I need to educate her on?
About infection.
Prevent infection, absolutely. So that's going to kind of be your focus when we're talking about chemotherapy agents. NCLEX may ask you about some particular ones, and I've kind of given you some information on those that I thought were most important. But chemotherapy is a specialized area, and NCLEX only tests nurses on what's the basic things you need to know to take care of a patient. And chemotherapy, you have to take certifications. I am not chemotherapy certified, never been. um it's never been one of my desires. um I will take care of chemo patients and cancer patients, but it was just too emotional for me. So um I just never became chemo certified. Um so if somebody comes into the ER, I need to know how to take care of them. And our biggest thing is to prevent infection and to keep them safe. Some chemo agents are going to, well, all of them target cancer in different ways. It depends on what's in the agent and what type of cancer it is. Some are going to work well together, some cause increased side effects if they are combined or used more than one. And then some have manageable side effects. My friend is on tamoxifen for 5 years. Post her stage 1 breast cancer. She had her mastectomy, but the side effects of the tamoxifen is or the side effects of some of the other medications she has to take because she's on the tamoxifen is worse than the tamoxifen itself. So it's just depending on what type of cancer it is and what's the agent. So, what's the anatomy of a cell? Remember, cells and cancer cells, because they are just cells, right? They can be, or they reproduce during a process called that cell cycle. Remember, way back from anatomy and physiology? And then during that cycle, that cell's going to copy the genetic DNA of itself, and it's going to mutate, and it's going to grow and then form other cells. So chemotherapy is going to kill those dead cells, and that's why some cancers are very fast growing. It depends on what the cell is, according to what type of cancer it is. So those fast growing cancers, bladder is one of those cancers that is very fast growing. Pancreatic cancer is very fast growing. However, patients don't really feel any symptoms until it's late stage. The same with ovarian cancer. So these chemotherapy drugs are going to interfere with that cell cycle, killing those bad cells. But in the meantime, it also can kill off some good cells as well. So the various chemo drugs are going to use different methods where, and depending on what type of cancer and what type of drug, where it's going to stop that cell division or where it's going to interrupt it. Is it going to do it in the interphase, the early prophase, the late prophase, or the metaphase? Just depends on what the agent is and what the cancer is. So your alkylating agents, they're going to be agents that are going to damage the DNA, and that's in hopes to prevent those cancer cells from dividing. They there are several different particular types. Some of the ones that I put on here are the ones that I tend to see or hear more. So, students that have just taken NCLEX that graduated in the spring have told me that there were no chemo medications on it, but there were questions related to how would you care for a patient who came in on a chemo agent. So again, it's back to those. What are we going to do as a nurse to take care of this patient that's on a chemo? We might need to put them on neutropenic precautions. We do need to prevent infection. We do need to recognize that they're going to have a lot of fatigue, that they're not going to want to eat, that they may have sores in their mouth. So we need to be doing good oral care. We need to not be clustering their care. We need to give them rest periods and give them breaks in between the many things that we need to do that's on our agenda. We need to worry about the patient and care for them. Some of your anti-metabolics are going to prevent those cancer cells from making the genetic material that they need to replicate. We use the 5-fluorouracil. It is a cream that treats a lot of your skin cancers. The 6 I can't even say it, mercaptopurine is gonna treat your leukemia, but it also helps with autoimmune disorders such as Crohn's disease and ulcerative colitis. Your hydroxyurea is specifically used for cervical cancer, but we also use it in the treatment of sickle cell anemia. So you see how we use some of these agents for other disease processes as well. Typically, your autoimmune disease, which your Crohn's, your ulcerative colitis, your sickle cell are all considered autoimmune disorders. The methotrexate is going to be for your leukemias, your breast cancer. It can be used for skin cancer, and it is one of your first line medications for rheumatoid arthritis, which again is an autoimmune disorder. Your topoisomerase inhibitors, I can't even say it. The etoposide is for Hodgkin's lymphoma, and we use it for ovarian cancer and testicular cancer. So a lot of your reproductive cancers. It's going to inhibit by preventing that enzyme from allowing the DNA to copy itself. And the topoisomerase is a specific enzyme that circulates in our bodies. The irononectin is for colon cancer. And then the irononectin liposomal is the first treatment for your patients for metastatic pancreatic cancer. So again, that's one of your fast growing. Colon cancer isn't necessarily fast growing, but your pancreatic cancer can be. Your mitotic inhibitors are gonna, these are plant based, and they're made of the same material that plants use to protect their own predators. So, because they are plant based, they work by interfering with the cancer cell's ability to divide and then to make newer cells. So, they stop it from making newer cells. Your paclitaxel is your Taxol, which we use for ovarian cancer, breast cancer, and then your non-small cell lung cancer. It's also used for Kaposi sarcoma in our AIDS patients. Your vinblastine is for breast cancer and uterine cancer. Your vincristine is for your leukemias and lymphomas. And then the vincristine liposomal is for your ALL, the acute lymphocytic leukemia. And then the veranobine is for the non-small cell lung cancer. Your anti-tumor antibiotics, again, we use some of these for other things or other illnesses as well. These are going to prevent the DNA inside the cancer cells from copying itself. In the meantime, they may damage some of the normal and regular safe or normal DNA. Your doxorubicin is for any of your malignant cancers. The doxorubicin liposomal is for any of your AIDS-related cancers. The epirubicin is for, it's IV for breast cancer. The mitoxantrone is for your leukemias. We also use that for your multiple sclerosis patients. Bleomycin is for your head and neck cancers and also testicular cancers, but we use bleomycin on warts. Dactinomycin we use for Wilms tumors, and your mitomycin for your GI, gastric, pancreatic, and some of your primary liver cancers. So again, I don't think that they're going to ask about particular medications. The ones they might possibly ask about, but it wouldn't be I don't think it would be in relation to cancer. They may ask you about your hydroxyurea for your sickle cell patient. So as a test taker, you might want to remember that it is a chemotherapy agent. The same with methotrexate for your rheumatoid arthritis. Any questions? Okay, so let's talk about chemotherapy agents as a whole. Remember, they're going to destroy those cancer cells. However, when they're doing that, they're going to kill off the good cells. We use them for all different types of cancers. Again, there's specific ones for the specific cancers. There's no real contraindications for chemotherapy agents as a whole, but it's just the risks have to out. I'm sorry, I wrote that backwards. Oh my gosh. It's the benefits have to outweigh the risks. Um, Side effects depends on the agent. Again, we see across the board a lot of GI upset, nausea, vomiting, and diarrhea. These patients tend to have a loss of appetite and lose weight. Some of the chemotherapy agents work best in conjunction with some of your corticosteroids. So if it's a corticosteroid that they're using it with, they may not have that loss of appetite. They may have increased appetite. So it's just recognizing that they're using corticosteroids as well. Some cause hair loss, not all of them. Thrombocytopenia is a adverse side effect. Again, fatigue. So we manage that by providing rest periods. Some can cause constipation, which is the opposite of that, nausea, vomiting, and diarrhea. So we need to increase fruits, fibers, and fluids. One of the common side effects is sores in their mouth, the candidiasis in their mouth. So good mouth care, good brushing their teeth, providing mouth care if they're not able to do it themselves. Some can cause anemia, so we need to be getting them proteins, high protein foods. And some can cause neutropenia, so definitely protect them from infection. Again, provide good oral care, treat the side effects, monitor those side effects. Remember, we want to hold that chemo if their platelet WBCs or their hemoglobin is too low. We can provide ice chips to help with that sores in their mouth or keeping their mouth from becoming too dry. Good skin care as well and preventing bed sores. We might want to get them small, frequent meals or whatever they can eat that provides them with protein. My mom passed away, unfortunately. It's been almost 30 years, but she was diagnosed with colon cancer way back when there really was no screening tools. She was 48 when she got diagnosed and 50 when she passed away. But towards the end, all she wanted was egg drop soup and Slurpees. So I'm like, you know what? Whatever we can get her to eat. Egg drop soup is not my favorite. In fact, I don't like it at all, but I would go get it for her. So sometimes it's just getting them whatever they need. I had to look at it that the eggs had protein, so at least she was getting some protein. Provide emotional support, administer those antiemetics. Again, that's about the time Zofran came out. My mom passed away in 1995, and Zofran was just becoming on the market at that time. It was very, very expensive back then. Encourage as much self-care that they can do. And then provide information on support groups. There are tons of support groups out there and support groups for the various types of cancer. Because, again, not all cancer is the same, and they may be having different side effects that they need emotional support. Don't forget the families when we're taking care of these patients, and provide, don't go get too caught up, but recognize the families and remember why we all went to nursing school, to help people, and then provide those rest periods as best we can. Does anybody have any questions? A lot of med. What's a lot of med?
No questions.
No question. A lot. No med questions. So I try to leave you guys with some inspirational quotes. They help me as much as they help you, and then we'll do some test questions. So we now accept the fact that learning is a lifelong process of keeping abreast of change, and that's what we do in nursing, right? And the most pressing task is to teach people how to learn. So I hope I'm helping you learn. I hope I'm teaching you how to learn. So, a nurse is caring for a client receiving heparin for a pulmonary embolism. The client's APTT is 120 seconds. Which action should the nurse take first? So, this is a priority question. Remember, with your priority questions, all the answer choices could be correct. You may do all these things, but what is the one that you're going to do first?
You stop. Stop the heparin infusion.
Stop the heparin infusion. Absolutely. Why are you going to stop that heparin infusion? That's the correct answer, but why are you going to do it?
To prevent further increase.
Because of 120
what?
seconds?
Yeah, that's way too high, right?
Bleeding.
Yeah.
What's the normal APTT?
Is it 60?
46 to 70.
46 to 70. Yep. So your priority is going to be to stop that infusion. Absolutely. Would we administer vitamin K?
No,
No.
protamine sulfate.
Protamine sulfate.
Protamine sulfate. Yep. Are we going to document the findings
Yes.
as?
Yes.
But read the question as therapeutic.
No. No.
No, it's not therapeutic, right?
Yeah.
So we're not going to document it as therapeutic. We're going to document the findings, but not as therapeutic. Are we going to notify the healthcare provider?
Yes.
Yes.
Yep. But after we stop the infusion, right?
Yes.
Now, would you stop the infusion, document, and call the provider?
You stop, notify, and document.
Right. I would obviously stop. We know that's the right answer. But I would contact the physician and then document it, because I can document it all at once. I can document I stopped it. I can time what time I stopped it. And then I can document what I said to him and what he told me to do, right?
Yes.
So kind of work smarter, not harder, right? A
Yes.
client receiving chemotherapy develops a fever of 103.1 Fahrenheit and an absolute neutrophil count of 400 millimeters. What is the nurse's priority action?
Notify the healthcare provider immediately.
Yep,
Yeah. B.
definitely. Notify that attending. So we don't always need to go straight to notify the attending, but look at your answer choices. Of your answer choices, that's the best one, right?
Yes.
We might initiate IV fluid infusion because he's got a fever. He could be septic, and then we would, but we're not going to do that first. What's Ask yourself, what's the one thing out of those answer choices that can help the patient the most? Administering that acetaminophen is not going to help right now. It's not, I mean, it's going to help the patient a little, but contacting the provider is going to be more beneficial because that neutrophil count is out of whack, right? And
Yeah.
reassess the temperature in an hour. I call that a do nothing answer choice. What's that going to do for the patient right now? Now that I recognize that fever is way too high, right? Especially if they're receiving chemotherapy. A nurse is caring for a client who received alteplase 2 hours ago. Which which of the following findings require immediate intervention? TPA is used for strokes.
Decreased level of consciousness.
Yeah. Why the decreased level of consciousness?
Because it's having an neurological effect on the person.
Yep. We look at our ABCD. Your decreased level of consciousness is one of your first signs of intracranial bleeding, which is a big side effect of your alteplase, right?
Yes.
And when we look at those other, okay, he's got mild nausea. Is that going to harm him? No.
No.
No, it's a
No.
side effect.
Is that blood pressure going to harm him? It's not great, but it's not going to harm him, right?
Yes.
And actually, if he's had a stroke, which I'm assuming he has because he got TPA, we want that blood pressure higher, right? We want it on the higher end so that we keep that penumbra being circulated with blood. And then they developed a small hematoma at the IV site. Well, that's probably normal, right? He just got TPA. And again, that's not going to harm him. A nurse is educating a student nurse on warfarin therapy. Which of the following laboratory tests should the nurse monitor to evaluate the effectiveness of that warfarin therapy?
B.
I
I now.
INR, yep. What do we use the APTT for?
For heparin.
Heparin, yep. What do we use the platelet count for? Or what does the platelet count tell us?
To uh, to
Bleeding.
check for the clotting, it helps in
Bleeding.
clotting factor.
To say what?
The
What's the
platelet
factor?
count know whether the person is prone at risk for bleeding or the platelet is too high. So we
Right.
use it to determine the clotting factor.
Yep. When would we measure a bleeding time?
Whenever they're on
When
anticoagulants.
we are giving heparin,
When we're given what?
they are on
Heparin or warfarin.
anticoagulants. If they are on anticoagulants.
I got three of you
When
talking at
they're on
once.
anticoagulants.
It's not going to be it might be for an anticoagulant, but a lot of times we'll do a bleeding time if the patient is going for surgery and has been on an anticoagulant, and we need to check to see how long it takes them to clot,
Okay.
especially if they're going for surgery.
So meaning we do bleeding time when we are going for a surgery.
Well, not always. They might do a bleeding time, but it's not
It's not a
If the
routine.
say again,
Said not a routine.
you said what?
Not a routine.
She said not a routine, like
Right,
not.
right.
Yeah.
Yes. A nurse is educating a client taking warfarin. Which of the following instructions is most appropriate?
C.
C.
Yep. Yep. Have your INR checked regularly, right? Would they take ibuprofen for mild pain?
No.
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 No, no.
No.
Would we tell them to increase their intake of green leafy vegetables?
No.
No, they have to
No.
reduce it.
Why wouldn't we tell them to increase green leafy vegetables?
Vitamin K.
It
Because
will
Yep,
it's rich
decrease
in
vitamin
the
K.
vitamin
effects
K.
of.
So
Yep,
when they take it, it's going to clot to the blood.
yep. And then we're going to tell them to use a soft bristle toothbrush, but not only if bleeding occurs. We
Yeah.
want to prevent that bleeding from occurring, right?
Yes.
Yeah.
A client on Epitin alpha has a hemoglobin level of 12.5 grams per deciliter. What action should the nurse take?
D.
So Epitin helps build hemoglobin.
Okay.
A.
This one's tricky because hemoglobin is different in males and females,
Mm-hmm.
and it doesn't really tell you if it's male or female, whether it's closer to that range.
So what would you do?
I
I would
think
go
I
A,
for I would go for
administer the next dose.
So what would be your best answer?
B.
Notify the healthcare provider.
12.5 is not very low. So I will
Right,
encourage intake of iron-rich food.
right.
Yes.
So
D.
for that reason, so I agree it might be a little tricky,
Mm-hmm.
but that's why I was trying to push you to think, what would you do? Because you may see this question and you may think it's tricky. It's not really a tricky question. 12.5 is not a bad hemoglobin level, right? A
Yeah.
lot of
Yeah.
times we don't even treat hemoglobin. We're not going to transfuse a patient unless it's less than 8. And we typically don't start treating patients unless it's less than 10. Now,
Yeah.
if it's 10 and symptomatic, then it's going to be a different story. But your ranges for your males to females are not that much off. They're only about 2 points. So is 2 points really going to make a difference? So don't try and read into the question. Just look at what is the best answer choice here. If you thought it was a tricky question, I mean that's a valid point. But if you thought it was a tricky question, how would you rationalize that? So for me, I would look at administer the next dose
Mm-hmm.
as prescribed. Well, I know 12.5 could be normal for a female, it could be a little
Mm-hmm.
low for a male. But would I really want to give it because it's kind of like that low normal, right? Is it going to
Yeah.
make it too high? Administer a higher dose of the medication, well, that's just an incorrect answer. And then encourage intake of iron rich foods. What's that going to do right now? Because the nurse needs to take action right this minute, right? So
Okay.
I can kind of get rid of B and E right away. Does that make
Okay.
sense?
Yeah. So the right answer is A.
No, the right answer is C. Notify
C.
the healthcare provider.
Okay.
What should we Notify the healthcare provider.
Because your hemoglobin is high enough, we're not going to administer that next dose.
Okay. Thank you.
Yeah. So remember, we don't really start to treat hemoglobin levels unless they get less than 10 and 8 if we're going to transfuse.
Okay, thank
So
you.
we withhold the next dose?
No, you notify the healthcare provider.
Notify, well, yeah, you would hold the next dose is not an answer choice. Your answer choice would be notify the healthcare provider.
Okay.
So if you were in real life and giving it, yes, you would hold the dose and notify the healthcare provider. But hold the next dose is not an answer choice on this question. Make sense?
Yeah,
Yes.
thank you.
Yes.
Yes, ma'am.
Oops, I missed the A. A client is prescribed clopidogrel after a stent placement. Which of the following is an appropriate teaching point?
B.
B.
B. Report any signs of unusual bleeding.
Yeah,
Yep.
B.
Yep. Why would he not take antacids? Or why is take with antacids to reduce stomach upset? Why is that not the correct answer?
Maybe it can cause bleeding.
Because clopidogrel is antiplatelet and it helps to prevent clots. So the more you give to the patient can be at risk for
For
bleeding.
bleeding.
So you have to monitor for unusual bleeding.
But what is that in relation to the antacids?
Do
The
the
antacid.
acids lessen the effect of the clopidogrel?
Yeah, it's going to interfere with the effects of that clopidogrel. Yep.
Antacid is going to interfere with the
Yeah, it's gonna interfere with the effects of that clopidogrel. So it could either cause increase platelets production or decrease because the clopidogrel is not going to work.
Okay.
Expects mild leg cramps as a side effect. Do
No.
we typically have leg cramps with clopidogrel?
No.
No. And take only if chest pain occurs?
No.
No.
No, it's
No.
not a PRN medication, right?
Yes.
It's a you need to take this medication, right?
Yeah.
A nurse is preparing to administer enoxaparin to a client. Which of the following actions should the nurse take?
B and D.
It's sub Q, so it's C and E?
I'll go for B and D.
D.
Okay.
BCD.
B and D.
BCD.
I hear B and D. B and D is correct. But y'all are missing one.
A.
C.
90
B,
degrees.
BCD.
B, C, D. Yep.
Um.
It's so enoxaparin is that low molecular weight heparin. We
Yeah.
do not administer it IM, it's sub Q. So A is
Okay.
incorrect. We do leave the air bubble in the syringe for two reasons. It aids in preventing leakage of medication, because if you try to get rid of that air bubble, you can lose medication. And remember, your medication is weight based. So we want that particular amount. And it also prevents bruising, which we're already probably going to see bruising, but it helps to decrease the effects of the bruising. And it also helps that medication disperse because it's most of it is injectable, like the auto injectors. Inject in the abdomen at a 90-degree angle. Do we do it at how do we administer sub-Q medications? 90 degrees.
90
Yeah.
degree and 45 degree, depending on the tissue.
Yeah. But we're going 45 to 90 degrees and we're going in the abdomen. What area of the abdomen do we need to avoid?
The umbilical.
Well, what is our landmark there?
2 inches away.
We 2 finger breaths around the umbilicus.
Yeah.
So do
And
we give
I'm
it the
sorry.
same as we give insulin? Do you give the injection the same as we give insulin? Because
Yeah,
I know insulin too should be.
Yes.
yes, it's a sub-Q injection. So you can give it in the same spot you give insulin.
Okay.
You
Thank
want to
you.
rotate your sites.
Yeah.
And then why do we want to monitor the platelet count?
Because it is an anticoagulant.
Yep. And then expel the air bubble before administration. Well, we already said we're going to leave the air bubble in. So that's an incorrect answer, right?
Yeah.
Everybody see that?
Yes.
This is a common type question with enoxaparin. Hint, hint. You might see that again.
Please, are you going to share the notes because some of us were not here when you started? Can you share the notes?
Can I share what?
The PDF. Is it possible to share the notes?
I tried. It would not load for me. The
Oh,
Naxlex site kept circling.
because I
So,
wasn't here when you started.
well, I can't share it while I'm on.
Okay.
So I've contacted I typically upload my slides an hour before when I have to generate the course. I share them at the same time, but I tried for an hour and it would not let me upload it. It kept circling.
Okay.
So I sent them to them about 8:30 to see if they could upload them, and I didn't get a response. And I don't think anybody is on from Naxlex tonight. I didn't see anybody earlier. Yeah, there's nobody on there. It is on Naxlex. Did you see it already?
Yeah, that is what HP is saying.
That is what?
That is
Yes,
what
it's
he's
on
saying, but I
Naxlex.
can't.
It's not. Somebody's saying it's not. So
CFLS, did you say it is there?
Yeah, it's there.
it is
Oh,
there.
Yes.
Okay. So
hi
then they must
CFLS.
have uploaded it there and not to, it might not be loading onto the Zoom meeting, but it's on the Naxlex site. A nurse is educating a client about iron supplements. Which instructions should be included?
BC.
E.
BC.
B,
BC.
BC.
And
But I have
E.
a question concerning the C, the D, take on an empty stomach, because the last time I was solving the question and one option was you take it in between meals and the other one was take it on an empty stomach. So which one is the right answer?
So you had a question, what?
Yeah, I had a question on iron and it was saying you have to take it on empty stomach. And the other one too was saying take
There,
it in
somebody
between
has
meals.
background. I'm not hearing what you're saying. Somebody, I'm hearing a baby and background more.
Oh. I was saying, like, I came across a question, and the question was when taking iron, it's good to take it on empty stomach. And the other one too was saying you have to take it in between meals. So I chose the in between meals, but they said you have to take it on empty stomach. So I was a little bit confused. So I wanted you to clarify for me.
Okay. So let's answer this question and then we'll talk about your question. Okay.
Okay. So I'll go in for B and C.
So we'll go with which answer choices?
B and C.
B and C. Okay.
Yeah.
So what does everybody else think?
BC.
Okay. B, C, but it's also B, C, and D. So we can expect that they're going to have dark colored stools because of the pigment in the iron is going to make the stools dark. If they are red or dark red, they definitely need to contact the physician. The straw, using a straw to do the liquid, a lot of times patients tolerate the liquid iron better. So we tell them to take it with a straw because it can stain the teeth. And then we tell them to take it on an empty stomach if tolerated. So iron is best absorbed if it's taken on an empty stomach and if the patient is taking vitamin C or ingesting vitamin C products with it. So, orange juice, grapefruit juice. If not, they can take vitamin C tablets. A lot of times, patients don't tolerate the iron on the empty stomach. So, we can tell them to eat. I would have to look at the question that you're asking particularly about, but this one is saying it's best absorbed on an empty stomach, but recognizing that not all patients can tolerate that. So, in between 2 hours would be typically the patients would be on an empty stomach. So, I can't answer the question that you had because I there might be something else to that question. But for this one, the answer is if tolerated. But we know that iron is best absorbed on an empty stomach, but not everybody can tolerate it. Milk is going to interfere with the absorption of iron. So we definitely tell them not to take it with milk and to wait that 2 hours between ingesting milk products. Did that help a little?
Yeah, thank you.
A nurse is caring for a client receiving methotrexate. What should the nurse monitor or teach the client about?
A and B.
A, B, D.
Good. A, B, and
A,
D.
B, D.
Yep. A, B, and D. Yep. We definitely want to avoid large crowds because why? This is a chemotherapy agent, right? The patient could have rheumatoid arthritis. They may not have cancer, or they may have cancer and they're taking it prophylactically for 5 years. We're still going to tell them to avoid large crowds or wear a mask if they need to, right? We want to monitor the renal and liver function because it can cause hepato or nephrotoxicity. We don't expect to see red colored urine. That would be abnormal. So they definitely need to contact the physician. And because it's a chemo agent, it can cause mouth sores. Take during pregnancy to prevent complications. Well, again, most every medication is contraindicated in pregnancy, but when it comes to your chemo agents, your benefits are going to outweigh your risks, but we're not going to educate the patients to take it during pregnancy because it can cause fetal demise and it can also cause fetal, you know, I'm drawing a blank tonight, y'all. I'm so sorry. Can cause abnormal growth of the fetus. I can't think of the word.
Teratogenic.
A nurse is administering filgrastim to a client following chemotherapy. Which of the following is the expected therapeutic outcome? So that's a medication that stimulates bone marrow to produce more neutrophils.
C.
C.
Is it C?
C. Yep. The purpose of it is to produce more neutrophils. So we want it to increase the neutrophil count. Absolutely. A client on warfarin therapy asks why blood work is needed so often. Which of the following is the nurse's best response?
D.
A.
C.
C.
I hear A. I hear D.
C.
Thank you. C is the correct answer. So think about what's the purpose of that warfarin, right? We want it to thin the blood. So why are we going to monitor those levels? To make sure it's thinning the blood effectively and that it's doing its job, right? Warfarin doesn't affect the blood sugar. And if it did, we wouldn't necessarily make them get a blood draw for a glucose level. We can do that a finger stick. Make sure the kidneys are filtering the drug properly. Well, the kidneys really have nothing to do with warfarin because warfarin's metabolized in the livers, not the kidneys. So we would more so want to manage or monitor the liver enzymes. And then to prevent dehydration from blood loss, that's kind of like a do nothing answer choice because warfarin, we want it to thin the blood, but we don't want them to have blood loss, right? Does that make sense why those are incorrect?
Yes.
Yes.
A nurse is caring for a client on doxorubicin therapy. Which of the following side effects should the nurse anticipate?
D.
Which
C.
one?
C.
A.
A.
Now, doxorubicin is a chemotherapy drug, correct?
Yes.
So
So A.
A.
maybe A.
D.
C.
We don't know.
We don't know. This is our first time.
It's
That's
between
okay.
A and
You
D.
don't know, but I'm going to show you a trick to figure it out if you don't know.
The reason
So,
For A.
why I chose A is I know they are just toxic on the kidneys. So far as there's renal toxicity, I'll go in for that, even though I don't know the answer.
so not all not all agents are excreted through the kidneys.
Okay.
So I'm gonna give you a tip to answering this.
Okay.
So I heard somebody say D. Has anybody ever died of ototoxicity? No.
No.
That's
No.
hearing loss, right? No.
Yeah.
So
Yeah.
we're gonna get rid of that one right away. Pulmonary fibrosis. Do y'all know what pulmonary fibrosis is? That's a long-term illness and it's thickening of the pulmonary lining. So people don't die of that acutely, right? So when we're talking about toxicity, we're talking about something that's going to harm somebody right away, right? Or
Okay.
pretty urgently. So we're going to rule out that pulmonary fibrosis and ototoxicity. Because ototoxicity's never killed anybody, and pulmonary fibrosis is a long-term illness. So renal toxicity or cardiotoxicity, that's what we're down to, right?
Yeah.
Which one is worse?
I do.
Cardio.
Cardiotoxicity.
Cardiotoxicity.
Cardiotoxicity, yep. Yep. So your answer is C. So
Wow.
look at what you have. If you don't know the drug, don't freak out, right?
Mm-hmm.
Narrow it down like that. What are my answer choices? And what could harm the patient? Because that's if you remember anything, I want you to remember. Remember, I said NCLEX doesn't always test you on specific chemotherapy agents, but it's going to test you on caring for a patient with on a chemo drug, right?
Yeah.
So it proved me wrong with this question, but I just gave you the tip on how to do it because you can recognize what's worse out of those four answer choices, right?
Yeah.
Cardio's worse than renal. We don't want either one, but which one is worse?
Yeah.
Make sense?
Yeah.
Do you think that's easy?
Yeah.
Not really.
Thank you.
Not really. Why not?
Well, because we have to decide, it doesn't say what is the worst thing to look for. So I don't know. I'm really thinking liver because it like chemotherapy would
Well,
be
liver's
probably
not an
liver.
option.
It's not. So I went to renal thinking cardio. I don't know. I just didn't even think to choose that one. But it is the worst case scenario.
It is the worst case scenario, but I will tell you something. Most of your chemotherapy agents cause a cardiac side effect, whether it's an arrhythmia, some can cause an MI, some can cause electrical disturbances. So, just knowing overall, and most of your chemo drugs cause they're not excreted in the liver. In the kidneys, they're metabolized in the liver.
So, like, is this one not supposed to be adverse effects instead of side effects?
So, no, it was side effects. But
Okay.
because cardiotoxicity is a side effect. I was just giving you tips because you didn't know the medication.
Okay. Thank you.
And that's just think about what could be worse and what
Okay.
is a worse side effect. So why would they, yes, ringing in the ears is uncomfortable and not great and can lead to hearing loss. But is that the worst of all of those four answer choices? No.
Okay, got it. Thank you.
A nurse is educating a client on bleeding precautions while on anticoagulants. Which of the following statements from the client indicates a need for further teaching? So we're looking for what type of answer choice?
False statement.
False. Yep.
B.
C.
B.
B. Take aspirin when I
B.
have a headache.
Yep. That we don't want him to take aspirin, right?
Yeah.
Because aspirin can increase that risk of bleeding by inhibiting that platelet aggregation, right?
Yes.
Yeah.
A client is prescribed methotrexate for non-Hodgkin's lymphoma. The nurse should educate the client to monitor for and report which of the following potential side effects.
C.
Sore throat for infection.
C.
C.
D.
D.
Huh.
D
C.
as in dog. D for dog, yes.
Okay, so let's go back to this. What I heard somebody say it right off. What is something I've preached about chemotherapy agents?
Infection.
Infection. So a sore throat
So A,
is a
sore throat.
sign of an infection,
Yeah.
right? Do you know what hypertrichosis is?
No.
No.
Excessive hair growth.
Excessive hair growth.
Yep. So we're ruling that one out. Red colored urine. It's typically your chemotherapy agents don't turn urine or discolor the urine. And numbness and tingling, has that, again, go back to what could harm a patient if you're not sure, right? Yes, it's a side effect, but think of it in the, because remember, NCLEX test that you can safely take care of a patient. So think in the lines of what could harm a patient. Can numbness and tingling harm a patient? I've been on a air mattress for 2 months because my house is still not done. So I've woken up with numbness and tingling in my hands because I'm just not sleeping in my bed, right? So is that harming me? Not necessarily.
But red colored urine, does that not mean the patient is bleeding? Did that not harm the patient?
Say, I'm having a hard time hearing every word. You're kind of cutting in and out.
Rifampin
I
is
said,
one medication that causes your urine to change color if you're taking it for tuberculosis.
Right. So rifampin, yes. Pyridium changes your urine, but that's not a chemotherapy agent. So I'm just making like a statement that chemotherapy agents typically don't change your urine color.
No, our question, what she just asked now is about the red color urine. Is that not indicative of bleeding?
Well, it could indicate bleeding, but is that a side effect?
No.
No. And again, what is worse? Red colored urine with a little bit of bleeding or infection and the patient's on a chemotherapy agent?
The infection.
Yep. 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 So think about what's worse.
Sore throat, so it's airway, breathing, and circulation. So
Well, you can look at it that way, but it's sore throat because of infection, because of the chemotherapy agent. That's that's the rationale for why that's the correct answer.
Thank you.
Thank you. Please, can you show us the site for alkylating type of drug for the cancer drug?
For what?
The cancer drug, the first group, the alkylating group. Please, I want to see them.
That one?
I can't see your screen.
That one? This screen?
Yeah.
Okay.
Yes, thank you.
Okay. Does anybody else have any questions?
I'm not sure. I'm writing them down.
Oh, sorry.
Thank you.
Thank you, Dr. Lapage.
You're welcome.
Thank you.
You're
Thank
welcome.
you.
Thank you.
You're welcome.
Prof, is it possible to get in touch with you if somebody wants to get in touch with you?
What do you need?
A specimen.
I can give you my phone number in the chat to you only for right now.
Okay.
Let me see. Can I even do that? I can't. Okay. And this is Lily?
Yes.
Or I can give you I'll put my email in
Okay.
I'll put my NASLEX email.
Okay.
Nobody's ever asked me that, but I don't mind. Okay. I just sent it to you.
To me?
Are you going to email me tonight so I can
Yeah. I'll
watch
just
more?
email you, but I can't see it.
It's in the chat.
Yeah, I'm in the chat, but let me see.
You're Lily, right?
Yeah, I just saw it. Yeah.
Thank you so much, Professor. We'll see you next time.
You're welcome.
Thank you, Professor.
I am off next week, y'all. I am going on vacation with my family and
Okay.
actually taking next week off. But tomorrow morning I was waiting on the new outline. So I'll start back the following week, which is the week of the 18th.
Okay. Enjoy
Thank
your
you.
holidays.
I'm hoping
Okay.
to enjoy my vacation.
Okay, thank you.
Okay, Professor. Professor, why is it hard for us to get the upload of the previous quiz and the Zoom that you guys are doing? Because all the time, like after you guys finish, I want to go back. I can't, like the next day. I can't see nothing.
So
I did send email to the technical support, and a lady respond to my text, but I'm still waiting.
do you subscribe to
Yes,
NASLEX?
yes, I did.
Okay.
I
Okay.
even paid the money. Yeah.
I I don't have anything to do with that end of it. I can reach out to them. I will send an email as soon as we get off, and let me give them your name.
Okay, thank you.
This
Asanatu
is
Afejo.
Hafanatu?
Yes, ma'am.
Okay.
Yeah.
I'm writing down your name, so
Thank
I
you.
will. They asked the last time y'all had some questions.
Yeah.
It takes a couple of days to upload. So the IT department is not, I don't think they're in the US. It does take, it takes about an hour, I believe, for it to download after I'm done. So from there, I don't know what happens.
Yeah, because that's what what one of the ladies said, one of the representative. Because even after you finish, like if we practice the practice question test, you're gonna only see it on the test, but not on the readiness exam. You cannot see all of those video. So I keep texting them. We keep communicating whilst I'm doing it. They said to do testing, but some open, some don't open. That's what the guy was texting me saying.
So some of them, I am very far behind on the readiness test that I'm supposed to do.
Okay.
So some of them I am far behind because I have not been in my house for 2 months. So they've given me a grace period till the end of September for me personally, but I'm not the only one doing them. So there are ones out there. Not all of them are going to have the explanations and the videos. I'm again, that's, they might be able to answer that question better.
Okay.
About the other ones, I'm not sure about why the other ones are not uploaded.
Yeah. It's just because they stated it said that, oh, you can go over the video like after you guys finish teaching us. So that's why I'm so concerned about it. Yeah.
Hi, Professor. Please, the time for the meeting, 9 p.m. Is it US time, 9 p.m. or?
Give me just a second. I'm sorry. Lily, I gave you, I forgot my email is not correct. Sorry.
Okay.
I just was looking. Give me just a second.
Okay.
I'm just putting the net. It's, I forgot one part of it.
Okay.
Okay. I'm sorry. What was that question?
I was asking the time for the meeting. Is it US 9 p.m. or?
There's two. There's typically two. One is at 7 and one is at 9. Mine are at 9 o'clock.
US 9 p.m. Eastern
Yes,
time.
ma'am.
Okay.
U.S. time. Yes. Eastern. It's Eastern time.
Yeah. Thank you.
All right. Well, if nobody else has any questions, Lily, I'll look for your email.
Okay, I'm going to send it right now.
Okay. I'm not going to stay on, especially if you're going to ask me something personal, because this is a record. It's recording.
Yeah.
And I can't stop it and stay on. It will just stop when I end it.
Thank you, Professor.
You're
Thank you.
welcome.
Bye. Okay. Bye.
Bye.